Hello and a very good evening to all. I, Dr. Dhammadeep Dabhade, on behalf of Emcre Pharmaceuticals Limited, welcome you all on the occasion of No Thrombosis. No Thrombosis is a scientific platform wherein we discuss, try to learn and understand about various clinical scenarios with the help of interesting cases presented by the eminent speakers, the practicing cardiologists during this program, and the cases will be discussed with detail by our expert faculties, the moderators and the course director. So just to share with you all about this program been there since last year. In the last year, this program been considered as the most engaging scientific platform by any pharma company in India. So with that note, I would like to now welcome the chairperson for this event today, Dr. Vilas Magarkar sir, who is the Chief Department of Cardiology and Interventional Cardiologist, currently affiliated with SET Nandalal Dutt Hospital, Aurangabad. I would like to welcome the moderator for this particular event today, Dr. Gaurav Verma sir, who is the interventional cardiologist from SMBT Hospital, Nashik. Then the speakers, so there will be two cases, the two case presentations in this event. The first presentation we will be having from Dr. Sumit Shezol, who is from the Medical Hospital Aurangabad, currently working as the consultant interventional cardiologist at Medical Hospital. Then our next speaker will be Dr. So first case will be on successful management of the LV thrombus. Very interesting case by Dr. Sumit. Then which will be followed by the challenging case in terms of interventional cardiology perspective from Dr. Abhishek Sakleja. So with that note, I would like to stop here and would like to hand it over to Dr. Magarkar sir for his opening remarks and then further proceedings of the event. Thank you.
Good evening and thank you, Dr. Deep. It is really, nice feeling to be associated with this program for now more than 1.5 years. We are conducting this program, maybe around 2 years since the beginning of first COVID wave. At the end of first COVID wave, we started this program. This, thrombus is considered as the biggest enemy of cardiologists. Interventional cardiologists are more afraid of thrombus. So continuously there is a research and development going on managing the thrombus. We keep on discussing so many things, includes mechanical devices for thrombus management and a pharma therapy for thrombus management. We have various antiplatelets, aspirin, ticagrelor, prasugrel, and now injectable cangrelor available with us. Apart from the previous molecules which we are not currently using, then we have GP blockers, and we have antithrombotic agents like low molecular weight heparin, fondaparinux, conventional heparin. We are now way ahead with, apart from the vitamin K antagonist, now we are having DOACs in our basket, and that is working very well in most of the situations apart from the non-valvular, apart from the non-mitral involvement, I would say. So, all these things are working well with us in order to tackle the thrombus. There are various interesting cases in the past also. Today also we have two interesting cases. We discussed so many cases in last 1.5 to 2 years that it was, great exchange of knowledge among the operators or among the cardiologists who were dealing with those thrombotic events, and my able and competent partner Dr. Gaurav Verma and myself could, learn also so many things from you people. Today, we are having two interesting cases. Dr. Sumit Shejul is a young, dynamic interventional cardiologist from Aurangabad. I request him to start his presentation on thrombus and how he did well with the LV thrombus management. Over to you, Dr. Sumit.
Sir, can I speak for a minute?
Yeah.
Good evening, Magarkar sir, and good evening to all the people present today. Before we go to our academic session, first let me congratulate sir on the this auspicious occasion of Guru Purnima. We all know sir is a mentor to many and inspiration to all the young cardiologists around, and we all know about his astute clinician sense. And sir is a learned teacher for all of us, and his pearls of wisdom since last 1 year, what we are experiencing is highly educative, illuminating, and informative. And sir has enlightened millions of cardiologists like us and made us wiser. So, sir, wishing you very happy Guru Purnima.
And thank you. You all are gurus. So our best guru is our patient, and we, everyone is a guru in his one or other form. So same to you, Gaurav. Thank you.
Exactly. With the last 1 year with this no thrombosis, we have become wiser in treating these highly thrombotic and high risk patients. So let us start with this first talk by Dr. Sejul. Over to you, Sejul.
Thank you, sir. Am I audible?
Yes, you are.
Yes. Happy Guru Purnima to Magarkar sir, our chairperson, and moderator Dr. Verma sir, and everyone. With your all permission, I would like to start with my case. This is an interesting case of thrombosis, and it is not just the LV thrombus. Starting with the case, are you able to see the slides in the slideshow mode or not yet?
Yes, your slides are visible. You can just attempt to make it maximize.
Yeah, I have maximized it now.
Okay. I think there is some technical glitch. If you can proceed, if there is.
Yes. So these are the slides. Now you are able to see the slide or not?
Yes. Your slides are visible.
Sir, I request Sumit sir. I request you to stop the sharing, and once you click on the share screen, no sir, then you will see the tab which is present in a presentation mode.
Yes.
That you can select, sir.
Tap in the.
Now you stop stop the share sir. Now I will tell you, sir.
Okay. Stop the sharing.
Now click on this share screen button, sir.
Yes.
Once you click on the share screen button, you can able to see one. There are some different tabs actually.
Yes, right? Yes. I'm seeing the different tabs, and there is one Microsoft PowerPoint tab of my PPT also.
Full, and there will be two. You can see one is one is in full screen mode, and second one is in just it's not in a full screen mode. Just select the presentation in full screen mode, sir.
Actually, I am getting only one PPT. I mean one tab only.
You select that one, sir. No issues.
Yes, I have selected that one only, and I'm sharing it now.
It's visible, sir.
Okay. So we'll proceed with the case.
Yes.
So is a 52-year-old gentleman. He came with the complaints of pain in abdomen and lower limb claudication. So patient came in emergency room, and he was admitted under surgical gastroenterology for the complaints of pain in abdomen, and they found out the abdomen examination normal. But because the patient also had lower limb claudications, his pulses were checked, and both the lower limb pulses were absent. Even the femorals were absent. So the CT aortogram was done, and that was suggestive of an atheromatous plaque in the middle third of the aorta with 50 to 60% luminal narrowing, and with the evidence of total thrombotic occlusion of the infrarenal abdominal aorta, and that was extending till the aortic bifurcation. Also, the inferior mesenteric artery was completely occluded, which was possibly the cause for the abdominal pain. And along with that, bilateral common iliac arteries had chronic total occlusion, and bilateral lower limb arteries also had mild to moderate luminal narrowings. So with this thing, we'll go to the past history. Patient had an history of ACS in 2002, but where details were not present. And he was admitted for 5 days, likely an ACS event, which was followed by angiography, which was suggestive of the non-obstructive lesions. So the patient had first ACS event at the age of 32, and that was the first ACS event. After which he followed the treatment for next 4-5 years, and then he left the treatment. And after that, he had a long-standing history of diabetes mellitus and hypertension. Patient is a non-smoker. Before 1 month, he had a history of TI, which was not thoroughly diagnosed, and patient was discharged on the second day. So with this history, because the patient had all the, because there was thrombus in the abdominal aorta as well as IMA, we did the 2D echo of the patient, and that was suggestive of anterior wall was scarred and thinned out with a large LV apical clot was seen, and the LV cavity was dilated with a mild mitral regurgitation. On ECG, there were QOs in the ECG from V1 to V5. And trop was positive, but it was marginally positive, not significantly higher. This was the size of the clot. It was a protruding clot, and it was occupying almost like 20 or 30% of the LV size. Patient was hemodynamically stable. His there were no complaints of chest pain, or there were no complaints of dyspnea also. The only complaint was pain in abdomen and bilateral lower limb claudication on walking only. So because of all these complaints, he was advised a surgical approach, but somehow patient was not convinced for the surgery. And he was willing more for the conservative management only. So what are the next options? What are the standard treatment guidelines for this LV apical thrombus as well?
Recording in progress.
ESC, they said we can use dual antiplatelet agent along with one anticoagulation agent. In 2013, ACC guideline was there for LV clot, and which said that it is reasonable to start an anticoagulation along with DAPT, and INR is to be kept around 2 to 2.5. And there was another one stroke guideline in 2014, which said INR can be kept about 2.5 also. So with all these guidelines, and because we all know that after 2018 and 19, with all the recent trials and recent data, and because of the very high bleeding risk with the DAPT and the anticoagulation, and with the successful use of single antiplatelet agent and the DOAC in multiple other thrombogenic conditions like atrial fibrillation or pulmonary embolism, the current consensus is towards using single antiplatelet with anticoagulation. So we started the patient on clopidogrel 75 mg and the full dose of rivaroxaban with the high doses of statin. After 2 months of the treatment, patient had history of PR bleed, after which he was again admitted. Meanwhile, his claudications complaint were reduced, and abdominal pain complaint was also reduced. But because patient had a bleed, we had to reduce the dose of rivaroxaban till to 10 mg, and then we titrated it in next 15 days to 15 mg. Totally, this was the echo done 4-5 days back. This is the images of the patient after 4 months. The size of the LV clot is now reduced, and if you can see that there is hyperechoic shadow at the apex of that clot. So it is likely, it is now layered clot, and it is now fixed. More likely, the chances of embolism are now less. So we did this thing, but what do the guidelines say? As I already told that these are the guidelines and these are the suggestions. But there was one interesting paper that was published in 2021 And the paper, this was regarding the use of rivaroxaban versus vitamin K antagonist on a triple therapy basis in LV thrombus after ST segment myocardial infarction. And this study was actually, it was not an RCT. There has been never an RCT planned in a LV thrombosis case regarding the use of triple therapy or any DOACs. But this was the retrospective and observational study which found out that the time for the LV thrombus resolution is lower with the rivaroxaban. If you can see in this chart that the final results are almost same. So the chances of resolution of LV thrombus in VK as well as rivaroxaban are same. But if we see that there is a quicker resolution of LV thrombus with the use of DOACs. However, this study was done with the dual antiplatelet agents, aspirin, clopidogrel, and rivaroxaban in the same dose what we have used. And this study also found out that the composite of net adverse clinical events, which were consisting of all-cause mortality, rehospitalization, as well as chances of bleeding, all of these findings were less with the rivaroxaban as compared to the warfarin. And if you can see in the left side, the chances that patient had a LV clot resolution were higher with the help of rivaroxaban at the end of 6 months as well as 12 months and 18 months also. However, there are no clear-cut guidelines regarding the use of medications in the LV thrombus. But this new paper is state-of-art review was published in JACC journal, and that was published in March 2022. This is the paper published by all the stalwarts in the field of cardiology, and that this paper is still they are suggesting that VK antagonists only remain the mainstay of the therapy because of the efficacy of the direct oral anticoagulant is less well established, and the data still is not that sufficient for the use of dual anticoagulants. However, there are many papers and there are many case series on the published since 2019 on this topic of LV thrombosis, which says that with the use of DOAC, the resolution of the LV clot is faster, and it is the chances of bleeding are also less, and patient also has to and the compliance of the patient is also good. This same paper has there was one flowchart in the same paper which said that if there is a presence of LV thrombus, then according to this paper we can use VK or DOACs with the P2Y12 inhibitors. The clot resolves, then we can stop the therapy after 3 months. However, if there is no if there is no thrombus, then this paper doesn't clearly suggest on the how much time to start, how many months next to continue the anticoagulations and what else can be done. So this is still the open case, and I would like our chairperson and moderators also, as well as all the panelists, to share their thoughts on this case, and what else can be done in this case regarding the management of thrombosis. His CT autogram we have not done yet. We are planning to do it at the end of the 6 months, and as well as regarding the symptoms of the patient, his pain in abdomen is relieved, his claudications of the bilateral lower limb is also now reduced, and patient is comfortable, but he is still not willing for the other surgical managements, and he is in follow-up with us. So what else can be done for these patients? So
interesting case, Dr. Gaurav, your opinion? Your comments, Dr. Gaurav?
Yes, sir. Sir, nice case, and this is one of the practical problems what we usually face, because this is like an off-label indication of DOACs. And like in the last meeting also, if you remember, sir, we have discussed that for such LV thrombosis, we don't have clear-cut guidelines. In 2013, like he mentioned, AHA guidelines suggested that we can use DOACs, but 2017, the European said that still warfarin is a better option, or vitamin K antagonist is a better option. But after that, like the case report, what he showed about Dr. Zhang's paper, which suggests that the time to resolution with a LV thrombus is better with rivaroxaban specifically. He is did not mention any other this novel oral anticoagulants. For these cases, then the protocol remains more patient based. If patient has a high bleeding risk, then of course we have no other option but to go with the NOACs, which has a markedly less bleeding risk, but time tested and as the guidelines suggest, because we don't have a randomized trial like Dr. Smith also mentioned. Then vitamin K antagonist like warfarin is a preferred option. And of course, when the thrombus is big, like in his case, I would have preferred warfarin, because that is more time tested. If you compare NOACs, NOACs are of recent onset and recent available in market. But whatever he has done is absolutely as per his patient's requirement and what he felt was correct, and we cannot debate that. But still, my question was that why, Dr. Sumit, you preferred clopidogrel than aspirin in your case?
Sir, because most of the papers, as well as whenever we use the combination therapy of DOACs, generally the P2Y12 inhibitors are preferred over ecosprin, and as well as the other P2Y12 inhibitors. So,
which study you are quoting about?
I can't remember the exact.
Because whatever the data what we have with NOACs means, if you talk about COMPASS and chronic syndrome, like your patient didn't have acute history of any MI, isn't it?
Yes, sir. Dropout positive, but there was not an acute event of MI.
So we may consider it as subacute, may not be acute.
Yes, sir.
Because in acute, the guidelines are clear, like in STEMI or in acute and STEMI, you have to use a dual antiplatelet with a NOAC or DOAC or VK, whatever you feel like. But in your subtype like patient, the data what we have is, if you take about ACS patients, then we have like Atlas TIMI 46, Atlas TIMI 51 studies. They have used aspirin with this on a background of whether you want to do dual or triple. This was the basic discussion, or what we can say about the COMPASS, that we know that all the GI bleeds or whatever the things what we fear with NOACs is a bleeding risk, and bleeding risk is markedly more with ecosprin if we compare with clopidogrel, and ecosprin has been targeted as a culprit for all GI bleeds in all the patients. Whenever there's a GI bleed, we first stop ecosprin and we continue clopidogrel. So the point of discussion or point of conflict was that why every trial with rivaroxaban specifically, of course with other, if we talk about apixaban like appraisal trial or some other trials like Pioneer HF or Redual, which were with atrial fibrillation per se. But if you talk about acute coronary syndrome like appraisal, Atlas ACS or Gemini, they have compared with aspirin specifically. They have left aside this thiopyridines or P2Y12 inhibitors. So still, whatever the small data, and of course not with LV thrombosis, is with aspirin and rivaroxaban. Right? This is what I feel. Sir, what is your comment?
Yeah, the case was very interesting, and the way Dr. Sumit tackled the case was very good. No doubt about that. Results are also good. I had few questions. A patient who had myocardial infarction in 2002,
yes, sir,
was fairly doing well. One, he had a TIA 1 month back. So yes, why echo was not done? Number one. Number two, then if the thrombus was there since 2002, as there is no fresh myocardial infarction, that organized thrombus, how it grown so rapidly to occupy 20% of the LV cavity, and that too, normally these thrombi, they epithelize at the end of 3 months or 6 months, more often than not, and they have extremely less chance of embolization. So whatever guidelines are there, they recommend to do echo, screen echo 3 monthly, and once there is a resolution, either complete or partial, or you can see that there is an endothelization has occurred, then chances of embolization are very less. Chances of cardioembolic episodes are 10 to 15% in fresh myocardial infarction in first 3 months when there is a visible thrombus on transthoracic echo. If 3 months are passed, either with your DOAC or with other measures, then this vitamin K antagonist, then the chances reduces subsequently, and there are very less chances. The chances are in the tune of 50% if the thrombus is large, it is mobile, and it is protruding, or there is an associated dyskinesia. All these things are there in the beginning period. Now we are dealing after 20 years of the previous infarction. Very, very surprising to have someone, an organized thrombus, epithelialized thrombus. Maybe we will say that there was a thrombus which was present at that time. Organized thrombus, well endothelialized, and still embolized after the 20 years of span. This is something which is really, you can say like this, unpalatable to me. Why this has happened?
Yes, sir.
Why this has happened? One thing, was there a fresh acute coronary syndrome? If it was a fresh, then in your case, there was no past history, recent past history of ACS.
No, sir.
ECG didn't show that. Your trop was not elevated to such a level to produce.
No, sir.
Then why this has happened? This is something which
Yes,
is
sir.
extremely, unpalatable scientifically. Because all these thrombi, they get endothelized, and then either they resolve or partially resolve or get endothelized. Chances of embolization are less unless you develop a fresh ACS. You may say that his apex was dyskinetic, but his apex was dyskinetic, then why it didn't embolize for so long duration? That is first thing. Second thing is, if he was not willing for surgical procedure, was there any role of keeping the pigtail catheter and give intra-arterial thrombolysis? That is commonly done by our interventional radiologists, and we used to do in the past with such large thrombus superadded on the the previous atherosclerosis or stenosis of the aorta. Here, the abdominal organs are jeopardized because of inferior mesenteric occlusion and a significant ischemia of the lower extremity. So that should be discussed with the relatives, which is a non-surgical option, and 24 to 48 hours of intra-aortic thrombolysis with the pigtail catheter from left radial route would be beneficial to dissolve thrombus and subsequently shift over to low molecular weight heparin, and then ideally vitamin K antagonist, as Dr. Gaurav has said, or you can go ahead with rivaroxaban also, because few studies are promoting it. Subsequently, following the patient every 3 monthly with the echo, as long as thrombus is there now, because it has migrated after 20 years as per the history. So as long as thrombus is there, in your case, he is the candidate for a lifelong oral anticoagulant, unless you document by transesophageal echo of total resolution of the thrombus. So one thing is, history is, 20 years is, I am little, not happy with that. The way there might be some episode few months back which patient has neglected or not noticed, that is possible, whatever it may be. But the thrombus has dislodged into the aorta. Already there was a baseline atherosclerosis and a stenosis. It occluded one important abdominal artery supplying an important organ, and it has produced significant ischemia of the lower extremity with bilateral non-palpable femoral. Because this is like if the thrombus dislodges at the bifurcation of the aorta, that is aortoiliac occlusion, if it occurs, then it is called as a saddle thrombus, and that is a Leriche syndrome. If this happens, then it produces bladder retention, this paraparesis, and impotency, and all those things which could be permanent also if not dealt with proper medicine and proper treatment in early period. So here we should have thought of something not surgical, then something extra apart from that. So these are few things which I suggested. And have you directly started with such huge thrombus and abdominal ischemia and lower extremity with rivaroxaban, or you started with low molecular weight heparin?
Yeah, yes, sir. Sir, actually, the patient was at the TI event. Patient could not was admitted at some other hospital. His echo was not done there. Patient came to our hospital for pain in abdomen, and after that he was, because of the He was advised regarding the surgical intervention as well as this intervention also. But patient was really reluctant for most of the treatment. So that's why he was not treated with all these interventions. He was advised the he was kept on low molecular weight heparin. Patient after that took the LAMA, went to other hospital. Then he came back after 2-3 days, and then again he was admitted. Again was given 2-3 days of heparin, and then was subsequently shifted on rivaroxaban.
Good. So that rivaroxaban therapy is not,
yes,
you know, it is not contraindicated. You will say like that is a choice of physicians now, and maybe after 6 months, as Gaurav was saying, after a year or so, the guidelines may favor DOAC also. But as of now, vitamin K antagonists are considered as superior in this LV thrombus. As far as the another antiplatelet agent is concerned, if you are using DOAC or if you are using vitamin K antagonist after an initial period, we should switch over to one antiplatelet. That is absolutely true. Which antiplatelet, aspirin or clopidogrel, is debatable. But remember, if you are using DOAC, then avoid ticagrelor. That is very, very clear.
Yes.
Aspirin, role of aspirin in peripheral arterial thrombosis is there. Clopidogrel has minimum role in peripheral arterial, So, as Dr. Gaurav has said, the multiple trials favor the use of aspirin along with that. Probably whatever trials you are quoting, those with angioplasty stenting and dual antiplatelet to begin with for 7 days with DOAC, and then after 7 days or 1 month, switch over to one antiplatelet with DOAC. There is a role of clopidogrel with DOAC. So that is probably in your mind that you were quoting. Anyway, it was an excellent case, an excellent thought-provoking case. Few things are still unanswered for me. Any idea from your end, Gaurav, how this could have happened after 20 years?
Sir, first thing, like you mentioned, that it may be since that 20 years. I doubt that it may have occurred recently, because such a big thrombus, the patient won't survive for 20 years with such a big thrombus. It will, bound surely. So that is what, when I look at the case, I thought it may be some subacute event, maybe in the last 6 months or maybe or so. In recent past, it may have happened. Second, like you said, that for these patients, we can start with the oral, this IV or subcutaneous LMWH. Again, I have some queries, sir, whether for all the trials what we have with rivaroxaban or Exafib20, they have started without combining with low molecular weight heparin. So sometimes I feel that either we should go with our routine protocol that we give for 5 days LMWH and then switch over to a VK, what we usually do, or just taking it forward, instead of VK giving a rivaroxaban or Exafib20. So that is one concern, that how you will proceed with this. Other is about the STK giving thrombolysis going to LV is very controversial, for the reason that people do have embolization with such things, and I don't know whether it is recommended, or what will you suggest for us? Like if we find.
I'm not talking of this thrombolysis into LV. I'm talking of putting from the left radial, putting a pictal catheter into the aorta above the site of occlusion, and give local urokinase or local thrombolytic therapy.
Because, sir, only the issue is that we fear embolization, because even if the LV, thrombus is in the LV, it is stabilized, and we make it a chronic state and let something endothelize, then we are happy. Rather than getting some acute stroke, we fear that, and not for these cases, but for valvular cases who comes with wall thrombosis, and when we give thrombolysis, we find sometimes that people do get massive embolizations. So I don't know about giving a thrombolysis in this scenario. But
right. That is like, one option which I was discussing, whether that was a possible.
No, I agree that it was a very big thrombus. But right. Do you recommend that we can try that? Means if the patient is stable, not acute state, like in this case, just came for a pain abdomen, and just we find an incidental finding on that, should we be so aggressive, or we should just give him a NOAX and just let him settle down? What he did?
Abdominal pain, ischemia, and inferior this epigastric artery occlusion is keeping the organ in danger, and there is a fresh thrombus, and we have, we notice that the thrombus has embolized from LV. Still, there is a lot of thrombus there. So the chunk of thrombus has already partially occluded abdominal aorta bifurcation. Femorals are not palpable. Mesenteric is totally occluded. Then we should go a little harder, I think, rather than this soft approach of rivaroxaban. And whatever literature says, it's like our sixth sense or our belief on the more traditional therapy. We prefer to give initial low molecular weight heparin for a few days and then stop that dose and switch over immediately to rivaroxaban. I know dabigatran and all those things, they require low molecular weight heparin overlap. In rivaroxaban, we do not need it. But in such large thrombus endangering vital organs of the body, there is a bladder, there is urogenital system which is there, which is partially supplied or in danger of the ischemia. So at this stage, better to have a low molecular heparin for a few days, 3 to 5 days, and then start with the rivaroxaban. Though the trial says that rivaroxaban can be started without low molecular heparin, but we should have, we have more belief on the time-tested thing which we have done for decades together.
Like one more thing, sir, you will go with rivaroxaban or warfarin, sir?
In this case, warfarin, definitely.
That is
LV thrombus is there. LV thrombus is more in favor of warfarin.
Warfarin, exactly.
And, yeah. LV thrombus is there, so I will go with warfarin.
Okay, sir.
Great, sir. Great learning, sir.
Great learning. It was interesting case, like whatever we are discussing, Sumit, it is just out of box thinking. That means after you manage the case and after 6 months, we are still thinking, that means you have done a great job.
Yeah, we don't have an answer.
Patient was stable. On admission, the patient was stable, and he had pain in abdomen, but he didn't require any surgery or intestinal resection. And
it was not gangrene, or it was not
gangrenous abdomen, or it was not. Yes, sir. Even the lower limb pulsations, even though they were absent, but patient's limb was not cold and it was not compromised. Even after 6 months now, the limb is not compromised and his pulses are now palpable. Patient came with the acute thrombosis of lower limb, and CT did show the saddle thrombus, but still there was no cold limb or bluish discoloration of the limb, or there was a gangrene. It was not the scenario. Even patient didn't require the abdominal resection and the resection on anastomosis of the intestine as well. So I thought it was,
fine. So that means there was no indication of going aggressive. That means there was
my
indication of
intention
going more aggressive. Yes. Now the issue is whether we should start with a low molecular heparin and switch over to warfarin with watching on INR, and once the INR becomes 2 to 3, then stop low molecular heparin and continue with warfarin and another antiplatelet agent, versus and low molecular heparin and DOAC, or only DOAC. So that is the only concern. So I think whatever you suggest, like whatever you did was a good job, but we should, in such situation, we should try more time-tested thing. And vitamin K antagonist still has an age in LV thrombus. At least right now, maybe after a few years, the guidelines may suggest DOAC can be used equally like vitamin K antagonist. So congratulate you, and you must post all of us the result of subsequent CT aortogram when we
Yes, sir. We are planning the CT aortogram at the end of 6 months.
And keep doing echo every 3 monthly.
Yes,
by this case, this seems to be a case of lifelong anticoagulant. What do you think, Gaurav?
This is what I was going to say, sir, that just continue the rivaroxaban. And one good thing is that in some trials, extension trials of the routine VTs, of course, we don't have with the LV thrombus, but with venous thromboembolism extension trials, like the Einstein extension, or with this for Exafib20 we have extension trials. In those they have said that we can even reduce the dose to half. Suppose you start with 15 milligram, you can just go away with 10 milligram OD, and the patient can take it for lifelong without much bleeding risk. If we compare with warfarin, that is an advantage with NOACs for long-term usage.
Already we are using rivaroxaban 10 milligram BD, 10 milligram OD in our long back treated patients of
pulmonary
embolism and all, and we are managing it because there was an obvious indication of continuing it for lifelong.
And sir,
if there is an indication of continuing it for lifelong, then that dose, small dose, that even there is an Einstein extension trial, there is an Einstein pediatric trial. They have used such low doses of rivaroxaban, but after initial treatment and after stabilizing.
One more, sir. Once the patient become more than 1 year, then he become a compass candidate as well. Then you can switch to rivaroxaban 2.5 BD with aspirin, isn't it?
But now, provided LV
he doesn't have events.
Disappeared.
Yes.
He doesn't.
If there is LV thrombus, then no.
No, sir. No. Let it be a LV thrombus. It will be like a chronic coronary syndrome with a history of stroke and peripheral vascular disease. You know?
That's true. But what about LV thrombus then? The indication for LV thrombus is not 2.5 milligram.
No, but again, sir, once it become chronic, we don't have indication. Even if the guidelines suggest, if it become chronic, you can think for stopping it also.
Yeah, but in this case, as it has embolized after 20 years, so here you have to be more watchful for the LV thrombus and give high dose or moderate 10 milligram dose. So
but
if the LV thrombus is resolved completely, then there is no problem.
But sir, what he showed that on follow-up, it reduced markedly, isn't it?
No, it's reduced markedly, but it is there. Transthoracic significant shadow is there.
Even if after 6 months it remains, still I won't be more considerate about the LV thrombus, because once it is stable for 1 year, I think it won't migrate. It can do whatever.
Extremely less chance. That's what I was saying. After 20 years, how did it migrate?
Yes, I think it was so big.
Almost unlikely, means theoretically unlikely. There must have been some small ACS which was unnoticed, or probably that your 1 month back TIA was with an ACS and ECG settled down, clot reappeared on the previously organized clot, and that clot migrated after 1 month. So that is more possible. And now, as you have done the HS trop T after 21 days, it is marginal positive or almost negative. So that is the more likely possibility.
Yes.
And another thing, Sumit, you have to search for the reason of such early coronary events in his case.
He actually had the first ACS event at the age of 32 years.
Right.
He was not regular with the treatment. After this thrombosis event, we did all his evaluation. His LDL was like 210. His LDL was 210. We started on high dose of statin, and last follow-up, his LDL was like 12. So we reduced now the high dose of statin to 20 mg statin now. We are using 20 mg. His last report was LDL was 12. But still, I mean, sir, this patient had the history of bleeding in PR and fissure after 2 months of starting rivaroxaban. So we reduced the dose. And again, now we are giving the patient at the dose of 15 mg once a day. So whether to reduce the dose after 6 months, even if the thrombus size doesn't reduce, or to continue 15 mg.
You get a aortogram done. If the thrombi in the aorta is reduced, and after 6 months, you can reduce it to 10 milligrams safely. That is not a problem. Anyway, you are doing an echo. My concern is, you have to check homocysteine, lipoprotein assay. Factor for this all thrombophilia profile, what we know, because this is thrombotic tendency, definitely, though the thrombus is there because of myocardial infarction and it has embolized, so it is a thrombus, but it is reappearing again and again. It has appeared at the age of 32. Infarct has occurred at the age of 32, that to 20 years back, when in India at that time myocardial infarctions were not that common at the age of 30. So he must be having some procoagulant condition. If he has some procoagulant condition which requires oral anticoagulation, then he is a candidate for lifelong oral anticoagulation. Whether it is a factor deficiency or Leiden factor, 1 Wilbrand, whatever it may. If it is a simple high homocysteine, then you can reduce down the subsequent oral anticoagulant disease and keep giving him supplementation for hyperhomocysteinemia. That is one more suggestion while doing the such thrombotic events, you can do a thrombophilia profile.
Sir, thrombophilia profile was done. His homocysteines were normal and proteins CS antibody level, I mean, those reports were also normal. So we couldn't find the reason for such a huge thrombotic profile.
That is clearly then dyslipidemia. That severe dyslipidemia with very high LDL has produced acute coronary syndrome. Acute coronary syndrome, extensive anterior myocardial infarction, dyskinetic LV apex, produced a clot, and clot has dislodged. So it's as simple like present case. Good. So congratulations. And let us move to another case. Dr. Abhishek is waiting. So he's waiting with pads on, but the opener batsman is not getting out. So, so go ahead. Please go ahead.
Good evening, sir. Good evening, Gaurav sir, Vilas Magarkar sir. Good evening, Sumit sir.
Good evening.
I'll share my screen, or you want to do it from your end? Mr. Ravi?
Yeah, share the screen for me.
Yes, yes. I'll just be brief because it is not exactly a case of thrombosis.
Sir, please make it full screen.
Yes, yes, I'm doing it.
You click this flash. Something is happening, Ravi, today.
Yes, sir.
Some technical glitch.
Right, sir.
Can everyone see, please?
Yes, yes, absolutely.
Okay. Yeah. So I'll be presenting a case of bifurcation PCI along with a critical lesion, which was done at the same time to complete the revascularization. So my patient was a 70 years female with a history of hypertension. She presented to us with a history of class 3 angina since last 2 to 3 months. ECG and echo was normal in that case. And the coronary angiogram showed LAD and diagonal severe disease with the Medina 011 classification. And LCX was having a critical stenosis with RCA having dominant RCA having mild disease. So we would plan to do PTCA to LAD-D1 bifurcation using a mini crush technique followed by PTCA to LCX in the same sitting. So actually I'm not able to bring the angio, but this is the guiding chute. We went via the right femoral approach with a 7 French guiding. As we can see, there's a severe disease in the LAD and diagonal, with LAD and diagonal being of equal caliber, like a dual LAD physiology. The left LAD is not having disease, but both the ostium of distal LAD and diagonal are involved. Along with that, there is a tubular almost 95 to 99% stenosis of the circumflex. So we went ahead with the strategy of mini crush technique with 2 wires one in LAD and diagonal. Both were wired and they were pre-dilated with 2.5 and 12 balloon. This was a check shoot which we can see after pre-dilatation of LAD and diagonal. As both the branches were important, we had planned a 2-strand strategy in this case. So both, as we had went ahead with the 7 French guiding, we could use both the stents simultaneously and positioned it, one in the cranial view and one in a iliacaudal view. At that time, we had lost the flow in both LAD and diagonals, and the patient had become unstable and was having chest pain. We can see the patient is keeping her fingers over the chest, as we can see in the cranial view. So we had to hurry up and quickly position the stents and deployed first the diagonal and then the LED stent was deployed. Because the patient had become unstable and there was some haste, so we had accidentally crushed the diagonal wire and balloon also. But fortunately, we could remove both. We could remove the diagonal wire and balloon without any problems. This was a check shoot after the dilatation of both the stents. The stent is deployed without any distal dissection, and the flow in both the branches is preserved. So we plan to go ahead with the rewiring of the diagonal. For that, we did proximal optimization of the LED with 3.258 balloon. Then the diagonal was rewired with a New York wire, and the ostium was dilated with a New York 2.5 into 12 balloon. Then for FKB, we put a 3.25 into 8 balloon, the same balloon we used for pod, and a 310 balloon in the diagonal. First the LED was dilated, then the diagonal was dilated, and then final kissing balloon inflation was done. So this is the flow post FKB. Both the branches seem to be well opened up, and with TIMI through flow in both the branches. There was no dissection, and the stents look well apposed and expanded. Next up, we went ahead with wiring the circumflex. The same wire which we used for rewiring the diagonal was put across the circumflex. There was difficulty in wiring, but it was finally done with using a 1.25 balloon, 1.25 12 support balloon, and then the lesion was again pre-dilated with the 2.5 12 balloon. This is the flow after the pre-dilatation. You can see there is some dissection in the distal circumflex. There was again difficulty in crossing the stent, so we used a buddy wire. Again with buddy wire, the stent could not be crossed, so we put a guideliner for additional support, and we could insert the stent after that. 2.75 into 28 test was deployed in the circumflex. We lost the flow in the OM, as we can see, but and there was some distal dissection, but the vessel was flowing, and we stopped at this point because we're not able to put additional stents because of the calcification in the circumflex and angle of the circumflex. This is the final cranial view of the bifurcation without the wire. So this is the case. Hello.
Yes, Abhishek.
Thank you. Thank you, sir.
Thank you, Abhishek.
Right.
Sir.
Gaurav,
Yes, sir.
What are the learning points as far as the thrombus is concerned in this case?
One is that when you are, taking a two-stent strategy, you have to be very careful. Like when you are expanding, you should keep a good, ACT check with your patient. Whenever you do this kind of bifurcation, you check ACT before and during the stenting, that when you take two stent and inflate two balloons simultaneously, you are lucky that no reflow occurred. One. Second, you should know the subset, acute coronary or chronic coronary. If it is acute, then high chances of no reflow, slow flow, which you should be careful. Third, like in wire, the circumflex, you lost the OM. So I would have kept a wire also there. So, and other, sir, there were debate about the technique, what should be used for these kind of narrow angles. So I'll like you to just enlighten us on this.
My question, in this forum of no thrombosis, no doubt the case is nicely done, but we have to, we have to highlight the thrombus. Was there any acute stent thrombosis, or there was some thrombus migration, or there was some after dissection there was some thrombus into the distal circumflex. Is it like that in this case?
No. So it is not related to the present.
No, sir, it is not.
Okay, fine. So it was not related with the no thrombosis.
No, sir.
Fine.
He just wanted to present a good case.
Okay, fine. That's good. So I agree with that. Let us go ahead with the interventional part as such. First, if there is a circumflex which is critical and there is a bad OM which is there, and LAD which is proximal to mid, where your stent is going to land near ostium, as you have to post dilate the stent, pot should be done. So you have to keep a sizable length of the LAD stent above the bifurcation. Here I would have gone first with the circumflex, because sometime, rarely, this happens that whatever stent you are kept in the proximal part of the LAD, sometime it may get dissected and you may have to put another stent which extends from ostium, sometime from the left main to LAD, and then you are in a soup of stenting the difficult circumflex because you have already crossed over it. So if you are dealing with the proximal part of the LAD, then first go ahead and do the circumflex which is critical, because then you have done your job and then you can peacefully go ahead with the LAD. If required, you can put your stent way proximal up to the ostium also to have a good post dilatation. In your case, there was a sizable length, but angioplasty is, we do thousands, we have done thousands and thousands of angioplasty, but we cannot say that the stent in the proximal LAD won't dissect or there would not occur any mishap to the ostium part of the LAD. In that case, doing circumflex would have been difficult. So if you are dealing with a critical circumflex and proximal LAD, better to go ahead with the circumflex first. Second thing is, as far as this dual LAD like diagonal is concerned, guidelines wise, study wise, everyone prefers nowadays with DK crush with few additional steps involved, 2 additional steps involved. Our main choice of dedicated bifurcation stenting, no doubt here there was a dedicated bifurcation stenting was required. Dedicated bifurcational stenting is DK crush. DK crush should have been a choice in this case. That would have avoided the hemodynamics derangement, accidental jailing of the wire and balloon, which could have created a issue if that wire would not have removed in time. So hemodynamics, thrombus formation, that wire getting entangled, not getting removed, getting coiled, all those things could happen. So if you are dealing with such situation, I think DK crush is my preferred choice with such large diagonal. Put a balloon, put a wire, both wire, balloon dilate, put a stent into the diagonal, pull it, crush it, and then go ahead with another sequential steps, simultaneous kissing, double kissing, pot. At the end again, Abhishek, whenever there is a dedicated bifurcation, the geometry of the stent is more favorable if you re-pot it at the end. So all dedicated bifurcation stenting should end with final pot. Here you have done an excellent job. The final pot you have not shown. Either you have done it or you have missed it.
No, sir, I have not done it.
Right. So final pot is not done. Yeah, if you have done a dedicated bifurcation stenting, simultaneous kissing, then the geometry of the stent, and after doing that, again post dilating the proximal part of the LAD stent before the both branches, that makes the stent approximation and geometry of the stent in such a way to prevent the restenosis at the distal end of the stent as well as at the bifurcation and carina. So final pot is, there is just an addition of one step. You already have a 3.258 balloon in your hand. Just put that, you can even remove that diagonal that is not needed. You can post dilate it in the proximal part of the stent with 3.25 at the optimum pressure. That would have helped to approximate the stent in a better geometrical fashion to the vessel wall as compared to one which we end without pot. What do you think, Gaurav? Final dedicated bifurcation, final step should be the final pot.
Agree, sir. Whatever you said, that this is what learning is all about, that we cannot miss any point. Because once you do these two simultaneously dilatation, you land up with elliptical shape of the stent, and you have to correct it with pot. So you cannot miss any step in this, because the results matter with these steps only. And as sir rightly said that DK crush is a preferred approach. But if you remember, Abhishek, we discussed that you can even do a culotte also. Now DK culotte is coming because the ankle is so narrow. Sometimes it's difficult to cross with such a narrow angle into the the side branch. So now DK culotte have shown almost similar results. We don't have a large data to support, but mini crush is slightly we can say an older technique, and we only prefer in emergency situation. And as sir rightly said that tackle circ first. Why? Because you don't know, you may have a left main the proximal LED dissection, which you may have to come back, and then you are happy that you have fixed circ also, because once you do that and you have to put a long stent from left main to LED, then you cannot address circumflex also. First address the titus lesion, or which can complicate the things later. You do that first. And other thing is, I must say that you should keep note of ACT. Keep you are quite fresh in this thing, and you haven't seen the complication of thrombosis occurring with these dual stentings. Then if you start practicing with the ACT from the starting only, you will be quite well off with your long-term result as well.
Yes, sir. Definitely.
Distal, that small dissection distal to the stent, as it was non-flow limiting, you left it?
Yes, sir.
Which antiplatelets?
He was on prasugrel.
Right.
He was on ticagrelor and aspirin and atvastatin.
Okay.
Yes.
One more suggestion, Abhishek, that try to do this bifurcation with imaging. You have IVUS with you. So whenever possible, try to do them with IVUS, because more often you find that either one of the stent remains underexpanded, like the sir said about dissections. You do such a good job, and finally you may land up with some complication later on. So always try to end up with imaging.
Yes, sir.
Good. Nice discussion. Deep, any comments from your end? Any questions which are there on the chat box?
As if now, sir, there is no question I could see.
Right.
Yeah.
Any question from your end, your end?
No question, but rather than, I would say there will be a comment. I will once again appreciate the case presented by Dr. Sumit. Nice and very thought-provoking case, which was having so many points to discuss. In fact, and what he discussed, that was really nice to listen. Actually, the way Dr. Verma suggested, I think that can be the consideration for low-dose rivaroxaban. But definitely, as you mentioned, it will be only and only after the complete resolution of the thrombus. So I think with that much insights from this case and with this interventional case, we are just about the conclusion part of this event. And just to thank, I would like to invite my colleague, Mr. Ravi, for the last words, the vote of thanks, and to conclude the session.
Sir, as you first of all, say a group of happy group to everyone, sir. And sir, since from last 1 year we are conducting this no thrombosis program, and I really think this is a time I think we should some changes we should do it next time. But this is the reason this time we bought one interventional case as well as the in-clinical case combination. And this was really excellent, because the two-way, because the audience will get the benefit of both the kind of cases. So
that's good, Ravi. You can continue with such things, because then there will be more panelists, more presenters will be there.
Yes.
So I did not know that. That's why I asked that question. I did not know that. Gaurav was aware of that. I think last meeting I was not there, so probably that was the reason. But good, Abhishek, you did a good job. That did bifurcation. All dedicated bifurcation stenting has an inherent chance of restenosis at the carina and at the origin of the branch. Whatever technique you use, there are certain plus and minus techniques of every, benefits of every technique. thinking you have to judge the you see the morphology, angle, diameter, length of the lesion, and the vessel caliber, all these things together, and the proximal vessel diameter, all these things together, it matters. So it's just whether it is a mini crush or decay crush, that hardly matters. There are a lot of opponents of decay crush says that decay crush should be reserved for left main and not for LED or all those things. So there are few people who top operators are, avoiding decay crush because of too much of a complexity and additional 2 to 3 steps and more hardware for a decay crush. So whatever you did is good. One more thing which we do when we do a complex angioplasties, multiple stents, more than 100 millimeter metal, or bifurcation, dedicated bifurcation stenting, irrespective of the patient's symptoms, at the end of 1 year, we do a check angiogram. We never ask for a stress test, CT angio or stress thallium after 1 year, which is a usual policy of do a stress test after 1 year. If the patient is asymptomatic, then switch over from ticagrelor to clopidogrel or just aspirin, depending upon all those things. But in such complex cases, one should do check angiogram, because this gives a lot of insight and ideas for us also for subsequent improvement. What happens to the diagonal? If there is a diagonal ostium which is pinched at the end of 1 year, then you can retrospectively go back to the the diameter of the balloon which you use, pressure of the balloon which you use for sequential balloon dilatation of diagonal. So this all gives us a lot of idea, all those things. So you can have a check angiogram of this, and having Ravi, as you have said, having 1 interventional case or 2 interventional case, 1 academic case or 2 academics, a good idea.
Yes,
that is a good change. You go ahead.
Thank you, sir. Thank you so much, sir.
Do you know?
So once again, sir, I thanks to Sumit Schedule, sir. Also, Sumit sir put a lot of effort, sir. So, sir has asked, some of the articles. He referred the articles. He gone through that, and after that, he has created his presentation. So, thank you, Sumit sir, for really a good presentation, and definitely it has got a lot of benefit to all our delegates. And once again, thank you, Abhishek sir, presenting a very nice, unique bifurcation cases. And once again, thanks to Gaurav Verma sir, and also sir Vilas Magarkar sir. Thank you so much, sir, for giving your time and valuable, very very insightful feedbacks to all our delegates, sir. Thank you once again from behalf of Emcre, sir.
Thank you.
Bye. Thank you all. Thank you. Good night. Good night, sir.
Good night,
And
sir.
happy Guru Purnima to everyone.
Thank you, Verma sir.
Happy Guru Purnima.
Bye bye.
Thank
Good
you,
night.
sir.
Good night, sir.
Good night, everyone.